Well, thank you very much for that introduction, and thank you for inviting me to speak. I'm always pleased to see the number of sectors who think it's worthwhile having an historian turn up and talk about the past and make sense of the future through the past. So I write about empire, I write about race, but I also write and make programs about cities and social history. And given that focus and those specialisms, much of my work looks at the origins of inequality and disparities in multiple different varieties. And in recent years, since the murder of George Floyd, I've written and I've spoken more than ever on race and the history from which racial disparities and racial injustice emerged. And like most historians, I regard it as my task to try to draw attention to linkages, to connections between the past and the present. And often those linkages are uncomfortable. They're uncomfortable for individuals and they're uncomfortable for sectors, organizations, and institutions. Healthcare is one of the many arenas in our society that faces some of that discomfort, faces a profound challenge when it comes to looking at the history behind those disparities. However, part of that challenge, I would argue, is that there is a need to confront the past and the power of the past, because the ideas we're up against are ideas that I think we have systemically and culturally underestimated. Because alongside many other institutions, sectors and institutions, the medical profession, the healthcare sector, has historically been part of the system that created modern disparities and indeed helped generate the racial thinking that underpins it. Some of my work is at universities. I'm professor of public history at the University of Manchester. And we have a similar struggle with our past and our future, which is that it is very difficult for people in universities who regard it as our job to highlight inequalities and disparities, to recognize that in Britain and in other countries, in the United States and across Europe, universities were the intellectual engine rooms for the racial thinking of past centuries that still shapes attitudes and outcomes today. There's something similar for many of our leading charities who struggle, good, decent people struggle with the painful reality that the wealth, much of the wealth, generated in the past that today funds their philanthropic activities often came through abuses like slavery or the exploitation of colonized people. The history of medicine, the history of healthcare has a similar history. It was fundamental to the generation of racial thinking. Racial stereotypes, pseudoscientific racial categories, all were generated, not just by philosophers, not just by slave owners and slave traders and imperialists, but by doctors. It is important to know this, not as those who are engaged in culture wars would suggest in order to wallow in a sense of guilt, because guilt, like pride, has no real place in any proper, mature analysis of the past. It's important to know this because it explains some of the health disparities in the 21st century. It helps explain our slow, stuttering failure to fully acknowledge, recognize, and address those disparities. I'll speak not just about race, but also about socioeconomic class, but to focus on race and its astonishing power. A moment ago I said I think we underestimate the power of race because we don't understand its origin stories. We don't talk about where these ideas came from. Race was made. It was constructed. It is structural because it was constructed. It was constructed deliberately and purposefully over centuries by the slave-owning lobby, by the colonial lobby, but also by universities, by the medical establishment, by multiple other institutions who were complicit in its formation. And that process of formation was vast. Huge amounts of effort, huge amounts of creativity, ingenuity, intelligence were poured into creating ideas that still shape our society today. If you read about the origins of the ideas that underpin the disparities of today, it is difficult not to be impressed by their sophistication, by the way these ideas can leap from generation to generation, by the amount of thinking and thought and careful creativity that went into their formation. To fight the effects of racial disparities, like other disparities, manifested in health, in criminal justice, in educational outcomes, in employment outcomes, I would argue, can only be done if we fully understand the scale of the idea itself, until we meet its authors and its architects, until we understand and we talk about the history from which these ideas were born. We can locate and we can qualify how race and powerful ideas about human difference that emerged in the 19th and the 18th centuries have real impacts upon the lives of non-white people today in the 21st century. And one of the best places to do that is within the medical field. One of the places where we can see the impact of ideas purposefully generated in order to justify racial inequalities and racial hierarchies in the past. One of the places we can see them operating in the 21st century that has been extensively studied is in pain and measures for controlling pain. Recent studies in both Europe and America have demonstrated that medical professionals regularly underrate the pain of black patients relative to white patients. The disparity in pain perception among clinicians is so stark that the pain of black patients is not just underrated relative to that of white patients, but often relative to that issued in the WHO guidelines. As a result, today, black people receive significantly lower levels of pain relief, often below those WHO guidelines. Today, in 2023, black patients are less likely than white patients to receive analgesics, even for fractures, even when reporting similar levels of pain. And this also applies to black children, whose pain is similarly underrated when they present in hospitals. The ideas that account for this are so ingrained within society that clinicians, people who have dedicated themselves to relieving the pain of their fellow creatures, are liable to imbibe and act upon these ideas. These ideas are so ingrained within our society that black people themselves, in study after study, have been shown that they have themselves imbibed that, and they themselves underrate their own pain relative to that of white people. But the reason an historian is talking about this is because these ideas are old. We can trace these ideas. We can find exactly the same concept, sometimes exactly the same wording in documents that are 2-3 centuries old. In all of the European empires and in the United States, we can find the origin of this idea that black people have a different physical relationship to pain to white people. In the British context, we could look at the work of the English doctor Benjamin Moseley, who in the middle of the 18th century travelled to the island of Jamaica. There he worked as a doctor. He cared for the wealthy plantation owners, but he also studied the enslaved Africans, hundreds of thousands of whom worked on the plantations of that island. And he wrote up his conclusions in a medical book called A Treatise on Tropical Diseases and on the Climate of the West Indies. And it is one of the first places in the British context where we can see the origin of the ideas, the myths about black people and their supposed insensitivity to pain in the English-speaking world. Moseley stated in his book that black people are, quote, void of sensibility to a surprising degree. Sensibility is just an 18th century way of saying sensitivity. They are, he said, not subject to nervous diseases. They, he said, sleep sound in every disease, no matter how ill, nor does any mental disturbance ever awake them. And in the same book, he made a claim that is repeated in books from the French, Dutch, Portuguese, Spanish, and multiple imperial contexts. Moseley argued that black people could, quote, bear operations, so surgery, better than white people. And what would cause what he called insupportable pain in a white man, what he called a Negro, would almost disregard. Moseley claimed to have personally amputated the limbs of enslaved black people who were able to hold the upper part of that limb because they felt so little pain. And again, that myth, that false claim is repeated dozens of times in dozens of different contexts, in different empires, in different languages, in different centuries. The myth that black people do not feel pain the way white people do from the very start was a myth that came from doctors. It originated from the medical establishment. Benjamin Moseley was not just a respected doctor, he became the Surgeon General of the island of Jamaica. If you flash forward a century later to the 1850s, we have another account from another context, another nation. John Brown was an enslaved man who escaped to Britain in the 1850s and who had been the subject of medical experiments carried out by race scientists, again employed by slave owners in the state of Georgia. John Brown, like dozens of former enslaved people who escaped from slavery in America, came to Britain and wrote what is called a slave narrative, a memoir. What's unique about it is he describes his experiences of medical experimentation. In his case, the experiments carried out upon him were intended to prove that black people felt pain less than white people because they supposedly had thicker skin. Those theories were alive and well a century after that, in the early 20th century, 70 years after that, in a very different context. They were present in the work of Charles Mangin, who was a race theorist, a French race theorist in the French Empire. He wrote about the supposed inner nature and physical attributes of black people in the French Empire in Africa. But Mangin was more than just a racial theorist. He was an influential general in the French army. And in 1910, he wrote a book called La Force Noire, which helped persuade the French government that black colonial soldiers could and should fight in any future European war. And again, he used the same arguments that were then 1.5, 2 centuries old about black people's supposed inability to feel pain the way white people feel pain. He wrote that the black soldier has a, quote, disregard for pain. He argued that Africans, as members of allegedly primitive races, had, quote, warrior instincts that remain extremely powerful. And again, he cited accounts by French soldiers that, oh, thank you very much. Thank you. He recited and regurgitated accounts by French surgeons who had operated on black people in French colonial Africa, who made exactly the claim that Benjamin Moseley had made 2 centuries earlier, to have operated successfully upon black people without the need of anesthetics. Mangin argued that black people had an underdeveloped nervous system which in some unspecified way enabled them to withstand not just the shock of surgery, but the shock of battle, rendering them immune to the post-traumatic psychological conditions that blighted white European soldiers. And he wrote that the supposedly low intellectual ability of Africans meant they were able to properly analyze their chances of survival in battle and therefore were less distressed by the thought of impending combat and less psychologically damaged having gone through the experience. He even claimed that African troops were so unperturbed by the experience of modern warfare that they were able to sleep through bombardments. And when the war arrived, Mangin personally commanded black soldiers on the Western Front, and he deployed them according to the pseudo-scientific racial theories that he and 3, 4, 5 generations of European doctors had developed. This is where these ideas come from. And modern researchers have revealed how they are still with us in the 21st century. The belief that black people are less sensitive to pain is so much with us in the ether that in one study in the United States, children by the age of 7 had imbibed those stereotypes about black people, their bodies, and that they were stereotypes that were written by men who'd been in their graves by then for centuries. A study of 2014 by Daw et al. Showed that when white and racially ethnic minority children were shown pictures of black and white children and asked to rate how much pain each child might feel in various hypothetical situations, not just the white children, but also the black children, said that the black children in those pictures would feel less pain. Other ideas about the nature of black people that have long historical roots have seeped into our society, our culture, and our subconscious. Let me give you another example briefly. In sports commentary, here in the United Kingdom and elsewhere, it's been shown that black players are far more likely than white players to be described according to physical attributes rather than intellectual attributes. They're far more likely to be described as tough, physical, or athletic, and far less likely to be described as intelligent or strategic. A study of 80 UK football matches from the 2019-2020 season carried out by the charity Run Repeat and the PFA analysed 2,073 statements from commentators and found clear differences in the way in which the attributes of players of different skin colours were described. Players with darker skins, as I said, were more likely to be reduced to their physical characteristics, while players of lighter skin tones to their intellectual capacities. When talking about physical athletic power, commentators were 6.59 times more likely to be talking about a player with dark skin. When talking about speed, they were 3.3 times more likely to be talking about a player with dark skin. But when talking about cognitive attributes, like work ethic, 60.4% of such praise was aimed at players with lighter skin. Similar patterns have been found in sports commentary in the NBA basketball and NFL football in the United States. And all of this is taken subconsciously. The commentators doing this, like the clinicians under prescribing pain relief, are unaware that they're doing it. They're unaware that they're influenced by ideas and stereotypes about the nature of non-white people that were developed centuries earlier. And some of those commentators are themselves black. These ideas about physicality, intellect, pain emerged between the 17th and the 19th century. They found their way into our society through the writings of race theorists and clinicians who worked on behalf of the slave-owning and slave-trading lobby. Those ideas were used to justify slavery and the violence that underwrote it. Those ideas about immunity to pain, about natural physical attributes, of course, made sense in a system that justified violence, brutality, overwork. These ideas are fundamental to any understanding of slavery in past centuries, but it would be wonderful to think they are of no relevance to our own society. It would be a relief if it was only people like myself who spend their time reading documents from those early centuries who had to think about those ideas. Concepts about race are underestimated in the 21st century because we don't understand their origins in the 18th, 19th, and 20th centuries. And we can see in multiple ways how those ideas were created, and we can see how they make the leap from generation to generation. In 2019, the European Social Survey asked a sample of the British public if they believed in a series of simple statements. This is one of those statements. Some races or ethnic groups are born less intelligent than others. 81% of people disagreed with that statement. That's more than 4 out of 5. That's overwhelming majority. That's far higher than it would have been had that question been asked in the 1980s or the 1950s. The same survey asked people if they agreed with this statement, and again, I quote, "Some races or ethnic groups are born harder working than others." 62% of people in the UK said no, they disagreed with that statement. And in both of those statistics, I stress the word born, because these are biological racial ideas from the 18th and 19th centuries. This is not forms of cultural racism. This is about innate, supposedly innate traits. 1 in 5 of our fellow citizens in 2019 believed that there's a correlation between intellect and this thing we call race. They believe it despite the work of generations of scientists who've demolished the idea that such a correlation exists, and more than that, have utterly discredited the idea that race is a meaningful scientific concept. Race is an extraordinarily powerful social construct, but scientifically it is meaningless beyond obvious physical traits like skin color, hair texture. There is more genetic difference, as you will know, between any two individual black people and any two individual white people than between all black people and all white people. Race has been utterly discredited, and yet 1 in 5 people in Britain in the 21st century believe there's a correlation between a discredited idea and intellect. And that's not just 1 in 5 people you might meet on the streets, that's 1 in 5 people who might read your CV if you're a young black person, who might be across from you in a desk in an interview, who might be your boss, who might be a policeman, who might be a teacher. Very much the minority, but enough people to do an enormous amount of damage. But they do that damage because they're carrying ideas that we have underanalyzed, whose origin stories we have not discussed enough. And now in the 21st century, after the murder of George Floyd in the remarkable summer of 2020, we find ourselves more energized than ever before in wanting to confront those ideas. Our capacity to recognize how they operate in our society, how they lead to disparities in health, in criminal justice, in education, in employment, has been enhanced. Now is a more important time than ever to understand and to tell and to discuss the origin stories of these ideas. Because combined with other forces, very often socioeconomic forces, they've contributed to the entrenchment of disparities, but they've also impacted on our capacity to even recognize such disparities in operation and our willingness at a societal, institutional, and even personal level to address them. And yet, there is, obviously, an enormous and hugely optimistic story from our own national history that demonstrates that Britain is a nation perhaps uniquely capable of confronting health inequalities and disparities. Because this is a country in which an epic 70-year field study has been undertaken, one that lowered disparities in ways that earlier generations would have found impossible to even envisage. The 75th anniversary of that start of that experiment falls this summer. That great experiment carried out at a societal level that was dedicated to addressing disparities based on socioeconomic class rather than race is, of course, the history of our most beloved national institution, the National Health Service. The NHS was envisaged in the years before its formation as a radical intervention to address the appalling, cavernous health disparities that were a near universal feature of British life right up until the late 1940s, despite the work of hundreds of charities and other organizations. The radical creation of the welfare states after the Second World War was a rejection, both by political leadership and by the population at large, of the enormous and appalling and often fatal health disparities that had been a persistent feature of British society. The landslide Labour victory in the election of 1945 was a collective national decision that those disparities, along with other forms of inequality, were not to be permitted to extend into the post-war future. There was, therefore, from that moment of its inception, a profound passion not just for the health service, but, in a way we've somewhat forgotten, for its mission. If you read the documentation, the reports, the books written in the last years of the Second World War in the lead-up to the formation of the NHS, they use different language. They don't talk about health disparities. But the NHS is born with a clear and present mission. The Beveridge report that laid out the framework for the future welfare state was, in many ways, not merely a radical perspectives for a post-war world. It was a publishing sensation among a population that was busy fighting a war that was not just against fascism, but it was for a new vision of the future. This vision of an end to disparities, of a rise of equality, was adopted, was welcomed in a way that we've never seen since. Hansard, the official record of the House of Commons, reported in a debate on the 6th of April 1943 that 250,000 copies of the full Beveridge report and 350,000 copies of the abridged paperback edition had been sold and bought in Britain. The Beveridge report was in fact so innovative a prospectus for a dramatic reduction in inequality and disparities in Britain that 42,000 copies were sold in the United States. And phrases from that report and from political speeches and other documents from the 1940s relating to this mission, those phrases became part of the atmosphere of wartime Britain, the atmosphere of progressive optimism. One of those phrases, burned into our national imagination from the cradle to grave, doesn't come from the Beveridge report. It comes from a radio broadcast made in 1943 by Winston Churchill. And it became as famous, although its connection to Churchill became forgotten, as any of his phrases from his great speeches after Dunkirk or the Battle of Britain. Within a month of the vesting date of the NHS, the 5th of July 1948, 97% of the UK population had applied for their NHS cards, the documents that would allow them to access the new service. But it was also within those first months that the NHS was thrust into the first of the many crises that have punctuated its long history. And that first crisis was precipitated by the vast, unprecedented task of addressing the legacy of health disparities. In 1948, overnight, the NHS took over the old voluntary hospitals, the existing local hospitals, the charitable maternity wards, the charitable TB hospitals, along with the rest of a complex, creaking network of inadequate health provision that the new system had been created to replace and augment. In England and Wales alone, the new health service took over overnight 2,688 hospitals. The NHS also took over caring for a UK population whose immediate healthcare needs were enormously amplified and exaggerated by decades of neglect and poverty that forced huge numbers of people to tolerate ill health, to live with treatable conditions and treatable disabilities. Historians often overclaim that we can learn lessons from the past. Often, rather than learn lessons, we just can recognize irony and accident. We can see how decisions made in one decade lead to unintended consequences in another. As a result of the legacy of neglect and poverty and health disparity that was inherited by the NHS in 1948, the service cost far more than had been anticipated. And the costs increased far above the expected budget. Management costs grew, as did the cost of improving and maintaining hospital buildings, many of which were in very poor condition, having been neglected for decades by health providers or charities that were often ill-equipped to meet the costs of maintenance. But the biggest problem facing the early health service was one that risked undermining its central mission, and that was the shortage of staff. One of the great ironies in the history of the NHS, that it was its need for labour that became one of the driving forces that led to an enormous increase in immigration into Britain from the former empire. That was the beginnings of the post-war minorities of today, who are today exactly the communities who are suffering most from health disparities. It was in this way that two aspects of British life and British politics became intertwined: the history and the present-day reality of the NHS, our most beloved institution, and the history and the present-day reality of immigration, the most toxic issue in British political debate for well over 70 years. Our passion for the NHS and its mission stands in stark contrast to the divided and often distorted debate about immigration, which fuses and merges with debates about race. Yet the NHS and the Windrush, the symbolic event that really marks that post-war wave of migration, are, historically speaking, twins. It was on the 5th of July 1948 that the NHS opened its doors, just 12 days after the Windrush had landed at Tilbury Docks. Once the NHS had been created, the nation rushed to register, and almost instantly there were not enough staff, especially nurses, to meet the demand. Not only was there a lack of nurses, there was a lack of people willing to train as nurses, and the true was same of other positions. The post-war economy overall was 1.3 million workers short, and thus the job market of the 1940s was a seller's market, and many single women, many of whom had just been liberated by being able to work in industry during the war years, were seeking to plan careers, or they were seeking to plan to become mothers because they'd put those decisions off during the war. And there was still a strong societal belief that men should work and women should be home workers. Thus, in 1948, there were 54,000 nursing vacancies. What filled that void was the factor that has always underpinned the NHS: immigration. The NHS, as we know it, became possible because of immigration from the outset. Indeed, it might never have become truly an NHS if it had not had those places filled by people who came to Britain, often from the former empire. In 1949, just a year into the health service, the Ministry of Health joined forces with the Ministry of Labour and the Colonial Office to reach out, with the help of the General Nursing Council and the Royal College of Nursing, to place adverts in the nursing press for women to come from the colonies, to apply for work as auxiliaries and trainee nurses. And from 1955 onwards, government set up schemes to assist people coming to work in the NHS with the cost of travel, although many funded their own journeys. Many overseas nurses ended up working in the Cinderella specialisms, the TB wards, the psychiatric hospitals, looking after some of the most vulnerable people in our society. And many people had their first encounters with someone of a different skin colour in a hospital ward. Over the coming decades, the British colonies became former colonies, and yet they continued to send a supply of often very well-educated labour that was critical to the future development of the NHS. By 1965, 5,000 women from Jamaica alone were working in British hospitals. By 1977, 12% of all student nurses in Britain were recruited from overseas. 66% of them came from the Caribbean. Between 1948 and 73, 100,000 nurses arrived from the Indian subcontinent, West Africa, and the West Indies. And during the same decades, there was extensive recruitment from India. In 1960, 40% of junior doctors were working in the NHS were from India, Pakistan, Bangladesh, or Sri Lanka. As we all know, those who came to help build the NHS endured and often experienced abuse. They encountered racism both within the wards and the corridors of the NHS and from the communities they served. A Home Office memo from 1949 framed this racial abuse as an issue that should be addressed not through anti-racism education or zero tolerance, but by setting limits on the numbers of non-white NHS staff allowed in any area. The memo stated that, quote, "It has been found that the susceptibilities of patients tend to set an upper limit on the proportion of coloured workers who could be employed either as nurses or auxiliaries." Yet these two phenomena, the story of the NHS and the story of immigration, have never been really seen as two sides of the same coin. The history of immigration in the NHS has long been one of political doublethink, a history of governments saying one thing and doing another. Because even as Enoch Powell was warning of rivers of blood, and Margaret Thatcher was warning of the country being swamped by immigrants, and even as the hostile environment was being rolled out after 2010, Britain continued to welcome doctors, nurses, and others from all over the world, often from the former empire. It was actively recruiting them. And the doublethink runs even deeper, as throughout its history, migrants to Britain have been working in the NHS while often routinely accused of, quote, putting the system under pressure. Debates about immigration have time and again focused on the belief that immigrants were coming to Britain as health tourists, seeking access to the NHS. Immigrants have been deployed by government as the salvation of the NHS for 70 years, while being presented by some newspapers as one of the greatest threats facing it. This, despite the fact that the use of healthcare services by immigrants is often thought to be lower than that of the UK population, in part perhaps because immigrants are on average younger. In many ways, the effect of the pandemic has been to illuminate the ways in which race and racial disadvantage operate within our society. Health disparities between communities have never been more obvious, manifest, and increasingly well researched. What has been remarkable about this moment is the way that government's been left behind. It's been academics, it's been healthcare workers, it's been researchers within the NHS itself who have brought this out into the light. The NHS Race and Health Observatory report of last year that deployed research by the universities of Manchester in conjunction with Sheffield, Sussex, and that cited 178 studies, presented evidence that, quote, ethnic disparities in health outcomes are evident at every stage throughout the life from birth to death. The pre-existing evidence of health disparities, the author noted, had failed to lead to, quote, significant change. The Race and Health Observatory's report also concluded that the health of ethnic minority people in the UK was affected by, among other factors, quote, discriminatory treatment from healthcare staff. As a result of such experiences, some from minority communities had, quote, delayed seeking help for health problems due to fear of racist treatment. I say this not to pick on the NHS or to highlight the staff working in the NHS or in healthcare in general, but to point out that what's happening in the NHS is merely what happens in a society that has not recognized the power of race, that has not confronted the stories from which these ideas came from, and is only now struggling with the challenge of recognizing that these concepts, these hierarchies, these beliefs are deeply, deeply ingrained in our society, our culture, and our subconscious. Last year's review by the BMA revealed in terms of how minority healthcare staff themselves are also suffering from discriminatory treatment, and you will know its foundings. Medics reporting that experiences of racism while doing their jobs was leading to a deterioration in their mental health. 42% of black and 41% of Asian doctors considering leaving or having left work in the past 2 years. 60% of Asian and 57% of black medics reporting that racism stands as a barrier to career progression, and a reluctance among health workers to report incidents of discrimination for fear of damaging their career or simply because they believe they won't be listened to and nothing will be done. This has been described as systemic failure, and therefore what is needed to confront it is a recognition fully of the systemic nature of racism. Yet rather than acknowledge how racism and discrimination are impacting our society more broadly and the NHS inevitably as part of our society, politicians often seek culture war headlines instead, or to use official reports to muddy the waters, or even discredit the notion of structural racism. Today, perhaps at any time, more than any time in its history, the NHS is better understood and better loved and publicly praised after the pandemic. The crisis it has gone through, and indeed the crisis it is going through this weekend, have been the focus of extraordinary national concern and debate, and the future of the NHS will inevitably be one of the key determinants of the coming election. Yet over the same time, never have its frailties and the health disparities that stem from them and from our wider society been better understood. Our deep respect and love for the NHS must not blind us to the fact that it and the political framework around it is in need of change. Innovations such as those you've been discussing here today will be critical, although it needs to be recognised, of course, that disparities within health provision are part of wider disparities in what is now the second most unequal country in Europe. We must not fail to recognise that the NHS, like other British institutions, has issues around diversity and inclusion that stems from a deep and poorly understood history, one that's left a profound legacy on our society. And it's because the NHS is special that its failings are so important. The police and the wider criminal justice system have likewise had a journey to go on, a huge discussion to engage in. And in both cases, healthcare and policing, there is no shortage of data detailing the nature and the consequences of those failings. The data shows the need for change, and our love of the NHS must never be unconditional. It can only be a truly national health service when it treats all communities that make up the nation equally. And yet the NHS has an enormous asset, an enormous advantage within itself. Because the NHS's astonishing diversity gives it unique connections to the communities who are suffering from disparities. There is no organisation in Britain better equipped, better populated to reach out, to share stories, to share experiences, to share empathy with marginalised communities along socioeconomic, along racial lines. The NHS is Britain. It speaks of Britain, it describes Britain, it looks like Britain more than any other organisation. That astonishing advantage, in my view as an historian, is one of the ways in which history can help us, can arm us for struggles of the future. The NHS's past should not be a disadvantage, it must be its greatest weapon. Thank you very much.